So we now come to the second speaker. Professor Eckstein, are you still online? Professor
Yes, I am.
Hi there. So thank you very much indeed for joining us, Prof. You're going to talk to us about early complications in initially uncomplicated aortic dissection type B are not rare. Should we intervene earlier? Prof, all yours.
Yes, good morning, everybody, and thank you again for inviting me for this fantastic meeting and very well organized meeting also, by the way. Well, should we intervene earlier in acute type B aortic dissections? I do not have any relevant disclosures to this talk. So more than 20 years ago, actually in 1999, Michael Dake from California published the first small series on patients with complicated aortic dissection, either rupture, malperfusion, or severe pain, and treated them with a very early version of an thoracic endograft as seen here. Early mortality was 60%. And from that on, we discussed the rationale of TEVAR for patients with acute type B aortic dissection. What are the reasons why we should consider that? So first of all, what's clear, we are able to cover the proximal anterior, and by doing this also to induce false lumen thrombosis. This might help to prevent any re-expansion of the false lumen, but it helps to re-expand the true lumen. Reopening of downstream vessel and avoiding secondary expansion are further aims. This is a big series from the International Registry of Aortic Dissections on more than 1,000 patients with type B dissection, and they detected an overall in-hospital mortality of roughly 10%. Significant predictors for this early mortality rate was increasing age, hypertension, very strongly associated with early mortality, periodic hematoma, very early expansion of more than 5.5 centimeter of the descending aorta, mesenteric ischemia was highly predictive, acute renal failure and limb ischemia. This is a patient from our own series. More than 10 years ago, he showed up after a day of back pain, not that severe, but we were able to diagnose this type B aortic dissection. And initially everything was fine, but after another 24 hours, he suffered severe chest pain again, got hypertensive, and was shocked due to this aortic rupture here. Unfortunately, we were not able at that time to stent graft or to treat it by any means. Immediately the patient died, and these are the autopsy material where you clearly see here the rupture site. 4 years ago, we published our own series of patients with type B dissection in the journal Vascular Surgery. And we looked at 68 patients, 78 of them were male with a mean age of 62 years for a time span of 14 years. We excluded, of course, A dissection and aortic dissection that started more than 40 days ago. All patients received the CTA on admission, sometimes the day after the next one, and then after 2 to 5 days, and after 10 to 14 days. And we looked at the incidence of immediate and delayed complications within this early period, so within the first 14 days. And we also tried to look at morphometric or morphological variables that might be associated with early complications. So this is our series of 86 patients. 64 were immediately uncomplicated, and 22, so roughly 25% of them presented complicated with rupture, malperfusion, or very, very severe therapy refractory pain. And then we looked here, and then it took a threshold at day 3 to 14, and 40 of 64 initially uncomplicated patients remained uncomplicated until day 14. However, another roughly 25% of the whole group, 24 out of 80/60, experienced delayed complications after day 3 with early expansion, new malperfusion, new refractory pain or hypertension, and 3 patients died by rupture, in one case, 1 day before the planned TIVA. And all this happened at a median interval of 7 days. So we tried to compare those groups with delayed complication and with no complications at all. And we didn't find any difference in terms of patient history, any other demographics, and clinical symptoms. So we looked at the morphological variables that might be associated with delayed or complications within day 3 and 14. And we found that a partially thrombosed false lumen was statistically associated with a delayed complication with an odds ratio of 3.5. And then also a true lumen collapse, so a secondary true lumen collapse, and the max has an odds ratio of 3.6 in favor of being associated with delayed complication, and that the maximum diameter of the descending aorta and the maximum diameter of the entry tier were also significantly associated with the occurrence of delayed complications. This patient was 50 years old, male, initially uncomplicated, but then after day 3 to 4, his pain came back with uncontrollable hypertension. So we took the decision to stent this dissection, and from that on, the treatment was easier. So what is our algorithm? Of course, we perform ECG, echocardiography, X-ray, and a CTA, always of the whole aorta, already in the emergency room. If the arch or the ascending aorta is involved, of course, we ask our cardiac surgeon to take over. Every patient is controlled in the ICU with blood pressure control and energetics. And as I said, all patients get serial CTA control. So if there is no rupture, no malperfusion, patients get treated conservative, and we consider TIVA in patients with early expansion, true lumen collapse, a big false lumen, and a big entry tree, and of course, really complicated patients with rupture, malperfusion, and organ ischemia have to be treated. And that's also recommended by the European Society of Vascular Surgery in 2017, where they said in complicated aortic dissection type B, TIVA should be the first line intervention, strong recommendation. In complicated aortic dissection, also endovascular fenestration, so I didn't mention that kind of therapy here, but this also should be considered to treat malperfusion and to prevent late aortic complication. Also an uncomplicated type B dissection, early TIVA may be considered. And this is supported by 2 studies, this again from the IRAD registry, in which after 5 years, people that were treated by endovascular means had a better survival than patients that were treated merely conservatively. And the INSTEAD randomized control trial also had a 5 years follow-up with statistically significant better outcomes after 5 years in patients who were treated by EVA. So in conclusion, should we intervene earlier? Yes, I think so, in highly selected patients with early expansion, true lumen collapse, early expansion of the false lumen, diameter entry of more than 18 millimeters, but we need, of course, more data on morphological predictors. maybe PET, CT, and biomarkers will play a role in the future. And a new randomized controlled trial would, of course, be the best. Thank you very much for your kind attention and the invitation.